We already talked last week about some of the drugs that are used in neurosurgery, but one of the things that you do need to be aware of is that anytime we do irrigate with irrigation solution, the temperature of it should always be below 120 degrees Fahrenheit. This is to prevent any burning or scalding of the tissue of the brain. So definitely always want to keep it below 120 degrees. And then also, we can use antibiotics in solution with injectable saline. If we do use an osmotic diuretic during cranial procedures, it's used to remove fluid from tissues and prevent swelling from a trauma. So it helps to reduce the swelling after trauma has occurred. Drains are often used in neurological procedures to evacuate blood, serum, and we also use them to eliminate dead space. Lumbar drains can be placed in the subarachnoid space before a surgical procedure if there is a CSF leak. So we can place that to remove CSF fluid from the spinal canal or the brain. They can also be placed to decompress tissue to bring it tighter in so we don't have such a wide dead space. And then also, if we do put a lumbar drain in as a actual procedure, these are done to monitor ICP pressure, which is intracranial pressure. So if there is a CSF fluid or if the brain is hemorrhaging or the ventricles are leaking and pressure is starting to build up, we will put this monitor in. It's a drain, ventricular shunt is what it's called, to monitor the intracranial pressure. If we are going to put in a lumbar drain as a procedure for ICP placement, obviously we would have a separate surgical field set up for that placement of the lumbar and ventricular drain. Suture. So most common suture used is for neural tissue. Why we use it is to retract, obviously. Sometimes we have to pull the scalp back to retract. We also use it for closure and repair. Most commonly what you're going to see a lot is like a 3-0 Neurolon. It's black suture. Those are commonly used in neuro cases. And then sometimes we can replace cranial bones if we are trying to, fix the dead space from a craniotomy. We can use wire suture to replace those cranial bones. So those are just some different sutures that you might see during neuro cases, but majority of suture is going to be the same as what you've been accustomed to in all other cases. Your Vicryls are often used on lumbar spinal closures. We do use some Vicryl in the head, but we try to avoid it because Vicryl is known to allow bacteria to grow. So you definitely wouldn't want to get an infection in a cranial procedure. Before we talk about cement, one of the other things I would like to cover is dressings. With dressings, again, like discussed in all previous chapters, it's going to come down to the type of procedure, what we've done. But what you're going to see a lot, especially with spinal incisions, what they like to place on the top of the suture is a telfa. So they'll lay a telfa down, a non-adherent telfa, and then they'll put the 4x4s or ABD or whatever the surgeon's preference is on top of the telfa, and then place tape or some type of sticky device to hold it on. What I commonly see is they will do Mastisol, then they'll lay the telfa so the telfa doesn't stick to the skin. Then they'll either put 4x4s or ABD on top of that and tape it down. So that's what I'm accustomed to. Most likely that's what you're going to see. On head, the types of dressings that you're going to see basically is maybe some 4x4s, maybe some telfa, and then they'll do a cling or a curlex and wrap it around, just like you've seen in the movies where they have the big cling wrapped around their chin and all the way around their head. That's a common dressing technique that they use for craniotomy procedures. Cements, we've talked about cement quite often, but the type of cement that you're going to see basically is the methyl methacrylate. They can use these. What I've seen them do a lot of times is for antibiotic reasons. They will take bone cement that's mixed with antibiotics, and so to help with infections, they'll roll the bone cement into little beads or balls, and they will place that in the wound, and basically it will help kill off any type of infections. There are some other types of cement they can use to close skin edges. that are not under any pressure. I'm not seeing that done very often. If in fact, I don't think I've ever seen it done at all. I have heard of it, but I guess you consider glue. So if you think about a glue as a type of cement, if we use Dermabond and stuff like that, that can be used obviously to close skin edges if they're not under any pressure. There's no tension on it pulling it apart. We can glue it together and it'll lay like it should. Anesthesia is the same. Most anesthesia for neurosurgery is always going to be general anesthesia. If we are doing like brain electrode placements, or we might be doing like a peripheral nerve repair for like carpal tunnel or something like that, it's not uncommon for those types of procedures, the minor procedures, to be done under light sedation. They're usually done in neuro for safety precautions. One of the reasons why we would do that is because we don't want to paralyze them. We need to make sure that there's communication between the nerve cells, make sure they can answer questions. If we're working on the brain and we're putting electrodes in to try to figure out what's going on with the patient, what lobe is affected if they're suffering from something, we want to be able to ask them questions. So it's important that we keep them lightly sedated so when we do ask questions, they can answer us properly. When I said carpal tunnel, usually for that, it's more of a peripheral nerve block, a regional block. Again, we don't want to paralyze the nerve during this procedure, so we'll just do a regional block. Some other considerations when we think about anesthesia that we really want to concentrate on is that we look at thermoregulation, which we've talked about this previously. Thermoregulation is just making sure that we are paying attention to the patient's body temperature. We definitely want to avoid hypothermia, especially since patients going under anesthesia for these types of cases can be very lengthy. So it could be a long procedure, so we definitely want to avoid the patient going into hypothermia. And then other things that we want to think about is if we do a smooth emergence from anesthesia. If you remember from the past, emergence means waking them up. It's important that while we're waking them up that we minimize the risk of laryngospasms and make sure the patient doesn't fight or struggle during the waking up process. So definitely want to make sure that those are some things that we pay attention to, or it's extremely important to take into consideration when we're waking patients up in neurosurgery from anesthesia. We talked a little bit last week, well, actually the week before, about positioning for patients. Again, long procedures, so we definitely want to make sure we pad all their bony areas so they don't develop any pressure sores. We also want to make sure that because we are working on the spine and the shoulders and the head, that we position them properly, that we don't cause any other injury to occur. Also, we talked about Jackson table, or Andrews table is another word for it, or Jackson table, Wilson frame Jackson table, which has the big horseshoe looking like pads on the top of it that we lay the patient on. Again, why we use these types of specialized tables is, one, it gives us good exposure to the spine. Secondly, because we use we use C-arm a lot during these cases, and so these beds are designed to allow C-arm or fluoro to get underneath them. They're also made of carbon fiber, so it allows the x-ray to travel through the bed and they can get a clear picture. So definitely we also take into consideration some positioning devices. I know I mentioned last week they can be setting up. We could use beach chair / type accessory equipment to the regular OR table. But we also, if we're working on the head or doing anything in the neck or head area, we can position them on head fixation devices like the Mayfield headrest. It has prongs, and then it also can have horseshoe gel pads just to lay them on. If we are using the Mayfield with tongs, another name is the Gardner-Wells tongs. If we need to have the patient's head in a specific position for traction, we'll use the tongs because they actually screw into the head. And then another term for these is called fiducials. I think I mentioned last week that's like my favorite word to say, but fiducials, those are the fixation devices or pins, prongs that go into the patient's head. If we don't have to stabilize the patient's head and they can just lay, we're working on their neck, so we don't need fixation so the head doesn't turn right or left. We definitely want limited movement, but we don't have to keep them in a certain position. They can just lay on the gel foam horseshoe pads and just it will keep their head in place, and they raise up enough to keep them from tilting their head right or left during the procedure. If we are going to remove hair during the prepping and positioning, part of the case, it definitely needs to be done only if we have to remove it. It definitely is only done because it's in the way. It interferes with surgery. We don't just go in and, we're doing a craniotomy and we're going to just shave the whole head. Usually what you find is they'll just shave the area where the incision is going to be made and there's a little patch. Sometimes the patient will request, like if you're going to shave a big patch in my head, if it's a guy, they might just request that you shave their whole head. But majority of the time we just make a cut. When we make the cut, we just shave over around that area where we're going to be making the incision. If we can avoid hair removal at all costs, we will definitely remove as close to surgery. And the reason why we wait till the patient comes back and is close to surgery is because if we were to shave their head over in recovery, they're probably going to freak out. If I was to have my hair shaved, I would probably freak out. I mean, my hair is valuable to me, those of us who cherish our hair. So you wouldn't want to remove it until the patient comes in. Usually wait till they go to sleep and then we'll shave the area. If we can not shave, if the patient's hair is really long and it's in the way, sometimes we'll use rubber bands and we will pull the hair back into sections and we will tie the hair rubber bands around the patient's hair, and divide them into sections where we can make the incision between each section and not have to shave. So definitely a lot of thought process that goes into when we are using razors or we're shaving the head. Also, if we do remove hair, if the head is shaved, sometimes the patient's hair can be saved and returned to the patient as personal property. So we would just go get one of those plastic white bags and put a patient sticker on it and then put it with our chart when we're transporting them to recovery. If we are going to be draping after we shave the head, sometimes it's not uncommon for us to sew the scalp to the drapes with silk sutures. So again, that's where we use suture for retraction. If we're using rainy clips or anything like that, you just want to make sure we have extra to pull the scalp back. If you look on page 953, what they're putting in pictures A and B, those are rainy clips. So that's how they're using the retraction. If you look on picture B up at the top, where the scalp is filleted open, the skin is pulled back. If you look at the very top picture, there's 3 little black ties. Those are sutures that have been secured to the drapes with cryos or hemostats. They've put the suture in the skin and pulled it back, and they've used cryos or hemostats to keep it in place for retraction. So nobody has to sit there and hold it during the entire case. So again, some other considerations to take into consideration. Definitely the craniotomy drape will have a fluid collection system because obviously water and things are going to drain down. So as soon as that is done, it will catch all of the fluid and it won't go all over the floor. If you don't have the drape there, you can use a kick bucket to catch the fluid as well. But most craniotomy drapes come with a pouch on them. Anytime we're doing burr holes, it's actually kind of a quick procedure. What's happened is there has been accumulation of either CSF fluid or hematoma on the brain, and it's causing pressure to build up, which is very serious for the patient. Most common reason why we do burr holes is for a subdural hematoma. Again, this is where blood will build up under the dura layer and it will create pressure. Anytime we have pressure on the brain, obviously it's going to cause too much swelling and the patient can die. For burr holes, basically we don't want to make sure that they extend beyond the layer of the brain. So that's why if you've ever seen a craniotome or a perforator, they are designed to where it won't let you cut. It only cuts to a certain position and it stops. It's like a safety stop on it, kind of like we've talked about before with the ortho saws and things like that when we're cutting off cast. For this procedure, in most cases, This is important to know. The surgeon uses a dura hook to elevate the dura. So they'll go in, they'll make the incision, they'll cut through the actual scalp and drill little holes, and then they will lift the dura with that dura hook. And then maybe make an incision with a 15 blade on a number 7 handle and puncture it down in the dura, and then they will drain some of the fluid, the CSF fluid that's built up, or the hematoma. If they do need to make a large opening in the dura, they will use mets and bombs and so forth to make that. But again, basically we're just drilling holes in the brain, and why we're drilling them in is to remove the pressure so that we can remove the clot or any CSF fluid to help the patient, so they can possibly restabilize themselves and get to normal pressure. If we're performing a craniotomy, usually it's because we are treating some type of intracranial condition, such as a neoplasm tumor, again, some dural hematoma. Something is going on with the patient. So when we do a craniotomy, it's an incision into the cranium to permit access to the brain and intracranial structures. If we do a craniotomy, obviously we have to cut into the skull and make a bone flap. So the bone flap will be created with the patient in supine, prone, or sitting position. And then when we remove that section of the craniatome, or the cranium, we use a craniotome to cut into the cranium to remove that bone flap. Obviously, the size of the flap is determined by the size and location of the tumor or where the injury is. So that's definitely important to know. And then you also need to take into consideration that when we are creating that bone flap and we remove it, we might at the end of the case put it back on the patient, or we may not. Either way, that specimen has to be saved. So at some point in the future, we're either going to bring the patient back and put the bone flap back on them and close up their skull, or we're going to put some type of implant mesh device to cover up that area to protect the brain. So I don't know if any of you guys remember during the state fair tragedy where Sugarland was here and the stage collapsed on a bunch of people in the audience. There was a friend of mine, actually a girl I work with, her cousin. She was one of the ones that was injured, and she ended up having to have an emergency craniotomy, and she had to have a bone flap created, and she went through about 3 years of recovery, learning how to speak, walk, everything again. And she walked around with a pink helmet to protect her, because while she was healing, she couldn't have the bone flap on, and obviously her brain needed to be protected. So anything she did in the public, she had to wear a helmet. But later on, they had to go back and put the bone flap back on. So when we send it off to the circulator, we pass it off. It goes through the process of being sterilized to be put in our bone freezer so we can put it back on the patient. So there is, you will learn all that. If you do neuro cases, you'll learn what happens with all of that. So in this case, just remember, oftentimes, depending on whether or not we have to use fiducials or not, if it's for tumor, we might use fiducials. If it's not, they're just going to be on a padded horseshoe headrest. For this procedure, patients or surgeons going to mark the incision line, including where they're going to make the burr holes. They might, draw a big square type incision to let them know where they're going to cut to make the cranial flap or the bone flap. And just know, again, drapes for this, there's going to be a fluid pouch to collect all the fluid as the blood is running down. So that's good. If we are using monopolar or bipolar, the monopolar will be used in the beginning when we're making the incision around the scalp edges to cauterize for hemostasis. But then as we get down to the dura and things like that, we will be using the bipolar. just know, for all intents and purposes, anytime we get into the dura, whether it's the dura of the brain or it's the dura of the spine, that's where CSF fluid is. So if you do cut into it, they are going to have a CSF fluid leak. So you'll notice in spinal procedures, they'll take suture and close that dura leak up or put a patch over it. On the brain, sometimes it's intentional that we get into the dura fluid. If it's building up and we need to relieve pressure, we definitely, we want that fluid to drain out until they become stabilized. Also, anytime we're drilling, what's the one thing we need for power or to keep the heat down? That is irrigation fluid. So you might irrigate a lot during spine procedures when they're drilling in the bone, as well as on the head or the cranial, the skull. So, and then there's one thing that we can also use if we are doing a tumor removal, and this is just for your own knowledge. There's these things called Gliadel wafers, Gliadel wafer, and these are wafers that are impregnated with an anti-neoplastic agent. And so we put these wafers in, and these are like, it's kind of like radiation. It delivers chemotherapy directly to the tumor. So these are just little wafers that are placed in the brain for patients who have to get chemotherapy and radiation down the road. So on a craniectomy or craniotomy, just know if it's one where the bone flap is not repositioned during closure, again, it can be replaced with an implant, or the bone is kept in sterile conditions and replaced weeks or months after the surgery. For this slide, all you need to know is a craniectomy is different from a craniotomy. It's usually done to remove bone from any region of the skull for decompression of the brain or evacuation of epidural or subdural hematomas. Most commonly, craniectomy is performed to remove tumors that lie in the posterior fossa of the brain. We talked a little bit about aneurysms. Remember when I told you that most commonly aneurysms in the brain happen at bifurcations, and it's because as pressure builds up from the blockage, it keeps hitting the area of the arterial wall where it bifurcates and it weakens the wall. So remember, aneurysms are weakened areas or bulges in vessels. And so cerebral aneurysm surgery, basically it's an intracranial aneurysm of a bulging artery within the cerebral circulation. So we know it's in that area, usually where the circle of Willis is, where all those vessels come together and communicate. So cerebral circulation. If it is a Berry aneurysm, so it's known as a Berry, B-E-R-R-Y. Basically, these types of aneurysms are commonly found at the base of the brain. So they call it a berry because it kind of bulges out and looks like a berry. It doesn't always happen at the bifurcation, and those are found at the base of the brain. We know that anytime we have aneurysms that happen, it can be because of a congenital defect or trauma of hitting your head or infection or blood pressure reasons. But obviously, they're at high risk for that artery to rupture and hemorrhage out, and it can be fatal. So it happens so quick. So it's important that if they do have a brain aneurysm, that we get them in and treat them as soon as possible. Majority of the time, they don't survive these. If they do, they've lost oxygen, so much oxygen to their brain, or they've stroked out, and there's further complications. So very, very serious injury. AVMs, arterious venous malformation resection. Anytime there's an abnormal communication between the artery and the vein, it's important that we go in and fix this. Not always. It's on the ones that are very important, the arteries that we need to salvage or save. So I shouldn't say salvage, that's get rid of. The ones that we need to save. So obviously, if we do want to keep them, we definitely will go in and fix it and do what we call an AVM resection. This procedure is very risky. Again, we're doing it to correct a fistula that occurs between an abnormal communication of the artery and vein, and it's most commonly diagnosed in patients between the ages of 20 and 40. Also, it's not uncommon for us to have an interventional radiologist involved in the preoperative care. And what they do is they help to embolize the AVM formation and to help tell us what we can do to reduce its size, or they might try to reduce its size before they come in and we actually perform the procedure. Why we do this procedure, what types of malformations we do it for is for cerebral aneurysms. And so we can go in and clip a cerebral aneurysm. Also, we can do it to help with microscopic dissection of those vessels that are feeding and bleeding out, basically. And so we can go in and identify the feeder vessels and fix that so we can reduce that from the bleeding from happening. Some other types of techniques that we can do to reduce the size is known as embolization. We can use platinum coils, glue, microscopic plastic particles, and we place these types of devices or agents in those feeding vessels as well. All of these materials or clips will close off those feeder vessels, which reduces the vascularity of the formation, because what we're ultimately trying to do is not have a rupture. If it ruptures, the patient will more than likely bleed out. Not going to go too in depth on craniosynostosis. We'll talk a lot about that in pediatrics. But again, when we suffer from this or a patient suffers from this, it's an infant, right? Because they have premature closure of those cranial sutures. And so if they close, then the brain can't grow to its size it needs to grow to. So if we do perform surgery to fix this, it's usually done between the ages of 6 weeks to 6 months. Again, because bones are still developing and they're more malleable, and obviously if we do, the earlier we do it, the better cosmesis result we get later on. For this procedure, just know you have to ensure that the irrigation solutions are warm, because with an infant, they're smaller, so they lose their heat faster and lose it through their head. So it needs to be warm to help reduce hypothermia in the infant. But again, you don't want it to be too warm because you don't want it to burn the tissue or the brain. And as we have advanced with future technology, we don't do these procedures open in an open technique as often as we used to. A lot of times they're being done with a endoscopic approach using a 0-degree lens, a 4mm telescope. But you can see the procedure on page 959 if you want to look at it and how they go in and make these little tiny incisions. And then they lift the scalp up and they go in and basically open up the closure, the defects, and allow for the brain to grow properly. So once they open it up, they will leave those sutures open and then they'll close the incisions and place dressing on the wound. Ventricular peritoneal or ventricular arterial shunts. Again, if we have CSF fluid that has built up and it's in excess and it's causing pressure to build up, we want to put this shunt in to pull that fluid away and direct it out of the body or down into the peritoneal cavity. So these shunts are usually placed anywhere in the body, but more commonly what you're going to see is that it's going to be a shunt that's running up to the ventricles of the brain, and then the tubing or shunt itself actually is run down. The catheter is run subcutaneously down into the peritoneal cavity where it drains out. Indications for this procedure to be done is hydrocephalus. Obviously, you're going to have a swelling in the brain from overproduction. It also can result from a condition that interferes with abnormal absorption of the fluid. So something's going on and the body's not absorbing it like it should. Hydrocephalus can develop in children and adults, and if it's persistent, it's going to interfere with cerebral blood flow and cause enlargement of skulls, especially in infants. For this, we want to make sure that once we do the procedure, if the actual shunt is open, that we handle it as limited, we limit our touching of the shunt to a minimal, because we definitely want to get lint or dust or glove powder on the actual shunt itself. Again, it's going in the brain. We often absorb it. We soak it, I can't talk today, I apologize, an antibiotic solution before we implant it. So that again can reduce the risk of developing an infection from placement of the shunt. So you can read through the steps, considerations for the procedure. There's a really good picture on page 962, what it looks like, where the shunt goes in, and where we run it subcutaneously down into the peritoneal cavity. So it's kind of cool to see these done. But transfemoidal hypophysectomy. This procedure is done where basically the patient has a tumor that's risen in the transfemoidal region, and so we need to go in and remove it. And the reason for this is because the bigger they grow, the more pressure it puts on cranial nerves 3 and 6. And so we definitely have to remove it before it causes irreversible damage. Tumors can damage the adjacent brain tissue, and so it can block the CSF flow or create pressure to build up. So for this procedure, we're going to remove all or part of the pituitary gland. And we've talked before, but we might use the Caldwell-Luke procedure, where we go in and access the sella tertia, which is inside the mouth, if you remember, to get to the pituitary gland. Patient will be placed in usually a 3-point pin fixation device for this procedure and put in semi-sitting position with the neck flexed toward the left and the head rotated to the right. Some considerations for this is if you have to plug up the incision area, you might need a fat graft. And if you are going to use a fat graft, you usually have a separate setup. And the reason for this is because the fat graft is usually coming from the abdominal area. And so that will have to be sterile. And obviously, if we're working in the mouth, it's just clean. So you need a sterile setup for the graft portion, and you don't want to use any of the instruments you've used on the mouth when harvesting the graft. You want sterile instruments to harvest the graft, and then for placement of the graft in the mouth area, you can go back and use the clean instrumentation. If you are doing a fat graft, usually the fat graft is taken first, and it will be used or it will be done in the beginning. So you'll start out sterilely, and then you'll move to clean, and you'll work in the mouth for the remainder of the procedure. So why we would do a procedure for, so we're covering some procedures that, laminectomies, pretty easy. So patient falls out of a tree. So microdiscectomy is something that, just like with the patient, obviously with neurosurgery patients, if you've ever heard of tennis elbow, so before I talk about doing peripheral